Thank you very much. Good afternoon and welcome. See, Lee, you were wrong. There's a huge turnout here. People really care about community health care. This is really a thrill for us. We've got an incredible panel that covers a very broad spectrum of healthcare, artificial intelligence, digital health, technology realms. And what we're doing is we're colliding them all into the area of community-based healthcare. So as you heard, I'm the president of a community hospital in just on the edge of metropolitan Boston, part of Partners Healthcare. And we struggle with many things to bring the highest quality, lowest cost, most efficient care to our communities. And one of the ways that we've sought to solve some of our challenges have been around this exact topic. So to have this panel here and to have all of you here to pose questions and provoke us to dig through these issues is perfect timing. As you heard, you have the WMIF app. I've actually got the iPad here that will allow me to see your question, and so we can actually, you can pose it, I'll see it, we can ask the panelists here. So please feel free, if you don't want to raise your hand or come up to ask, you can just type away. So let's start off with this concept of community-based healthcare and telehealth. How does that work? Well, let's go beyond concepts of patients who don't want to come into a doctor's office for routine follow-up. They want to do it through their iPhone or they want to do it through their computer. I think we all understand what that business model could look like. But what about actually providing care in a community hospital that's beyond the capabilities that a community hospital normally would be able to offer? So let's say a patient comes into an emergency department in my hospital and needs a complex, urgent surgical procedure. And for all host of reasons, they can't be transferred to another tertiary care facility. Time, acuity, emergency, or we have the surgical expertise, but it's the post-operative management that's hard for a community hospital to staff all the time. This concept of critical care and telehealth through an ICU platform. That's one fabulous example of how using technology, using telehealth, and I know we'll get into this, we can expand the capabilities of community hospital to provide first-rate care with affiliations through systems. What about this concept of artificial intelligence? So last year at this panel, we talked about how artificial intelligence can help physicians order the appropriate test. Well, we're going to try and go beyond that. Let's talk about using artificial intelligence to screen for diseases in a population in a community and to impact that screening through assessments by artificial intelligence as to whether that patient, through the screening, needs follow-up or not. So there's a great example of how artificial intelligence can help us look for illnesses before they become clinically relevant or a patient comes to ask for help and actually provoke their way into the system to get appropriate care earlier. Another great example is how does a community hospital, particularly one that's not in a large health system and has to make decisions about what products to buy and what are the challenges of working through channels to operationalize those acquisitions. How can we work together through a digital health, artificial intelligence world to make those decisions and impact patients positively? We're going to get into that today. And then what about digital technologies in general? Where are the impacts that digital health can have on patients who come to their community provider? It's well beyond going to a CVS Minute Clinic, not to say that those aren't transformative sites of care, but there are technologies that would allow interfaces between patients, their providers, and the system that will catch diseases sooner, implement therapy faster that's most appropriate, and preserve the outcomes and quality of life. So I think we've got, the challenge we're going to have is the time, because we've got so much to talk about. So to start off with, I'm going to have the panelists introduce themselves in order. We'll start with Dr. Schwamm. Each panelist will tell you what their level of interest and what they're doing in their worlds to address some of these issues, and then we'll dive right into this. And again, I'll just remind you, use the app if you'd prefer to type some questions as we go. So Lee?
Thanks, Mike. It's great to be here. My name is Dr. Lee Schwamm. I'm a stroke neurologist at Mass General by training, but I've been in the field of telehealth for about 20 years. started off building really a platform for providing acute stroke expertise to patients who were arriving in hospitals in the late 90s and the early 2000s when TPA, which is a clot-busting medication, had first been approved for use, but nobody felt comfortable using it. And now direct our hospital Center for TeleHealth, where we're looking at using those kinds of tools to provide staffing solutions across our entire network, including our community hospitals, and also thinking about ways that we can leverage both synchronous and asynchronous care to improve the quality and create a more standardized experience for patients as they move through our system.
John?
Yep. I'm John Miller. I'm on the Retina faculty at Mass Pioneer. At Mass Pioneer, I serve as the Director of Retinal Imaging, both has an oversight of clinical operations and network management to our many community sites, as well as managing the Retinal Imaging Lab, where we explore novel imaging devices as we look for new biomarkers. The eye remains a critical window to both monitoring systemic disease and a variety of ophthalmic conditions.
Fabien.
My name is Fabien Beckers. I'm the CEO and co-founder of a company called Arterys. We are an online platform for medical imaging, so a lot of community places and around the world, medical imaging is really on-premise, so you have to deploy on-premise solution, and therefore all the expertise have to be at the location of the imaging acquisition is done. And a lot of the work also is really manual today, so you need a lot of expertise to that work very well. So we created a web-based, the first of its kind web platform with AI embedded into it, so anyone can have access all over the world, and therefore the AI can also bring help, leveling the playing field with expertise, have early and accurate detection of cancer, for example, and help all those physicians assist them while having a workflow integration piece of it. So we think that will transform healthcare from an early and accurate standpoint as well as diagnosis standpoint.
Joanna.
Joanna Geisinger. I'm the founder and CEO of a company called TORq Interface. I founded that a little over 3 years ago. I used to work as a device vendor in a lot of the surrounding New England hospitals, including Newton Wellesley, and I just saw a lot of push-pull between the hospitals and the device companies around cost, and I felt like there was a lot of opportunity to maintain patient care or even improve patient care while reducing costs for both the hospital and the med device companies, simply by eliminating a lot of the mundane manual work that technology could handle. So we're in a digital age where everything's on your smartphone. As a device vendor, you're required to go into certain types of procedures, orthopedic being the largest segment of that, where for a total knee, for example, there's always a device vendor that's in the operating room assisting a surgeon to implant a device into a patient. It's because technology is constantly evolving and these vendors stay up to date on that technology. But sharing the surgical schedule with these device vendors that live outside the electronic health records and that single source of truth poses risk to the patient, also is extremely time-consuming for the hospital staff in order to share that information with the vendors. And it's very difficult for the device vendors to do their job well without insight into when the surgery is actually happening. So delivering product 48 hours in advance of a surgery to be sterilized and then showing up on time for that case. So my company really just looks at how can we eliminate a lot of the physician and clinician burnout. I know that's a really big buzz topic right now, but I think there's a lot that technology can do without changing workflow, and that's what we focus on.
Tal, maybe when you tell about your current thing, tell a little bit about what you did before this.
Sure. Thanks, Mike, and thanks, everyone. I don't know if you can hear me, but my name is Tal Wenderow. I'm the CEO of Beyond Verbal. Beyond Verbal is using voice-enabled AI to monitor your health. It's a company with an R&D lab in Israel, headquartered here outside of Newton. And by analyzing your voice, so listening to the way you say things, not what you say, so not speech recognition, and using big data technique, we can monitor health. We are in late research stage of approaching commercialization with the goal to really monitor your health on a continuously manner, because voice is a really truly passive sensor of your body. There's a lot of sensors, and how do you use that to triage, and how do we treat patients, and how do we get the best physician to look early on onset of disease or deterioration of disease. That's on Beyond Verbal. Really, the latest result is ability to, by a single call predict hospitalization and mortality of chronic patients. That's based on 12,000 patient database and research that we've done. I joined the company actually 2 months ago. Before that, as Mike mentioned, I was the founder of a robotic company doing telestenting, especially for stroke. So started with coronary, peripheral, now moving to stroke. So I'm a true believer in telemedicine, whether now I moved to the early detection. Before that, I was on the back end, on the treatment side.
Great, thanks. So you can see huge perspectives here, all sorts of different avenues. But I'm most thrilled, panelists, to let you know that there already is a question, and it is worth pulling it right out. And Joanna, I'm going to put this right on you. So it says here, how can we make sure women are included and heard in the healthcare transformation? Unfortunately, there's only one female panelist. I'd say fortunately we have a female panelist. I'd assume there are many women who have a lot to say on this topic, especially in community hospitals. So on a broader perspective than that, give us a sense for kind of your pathway to get to where you are today.
Well, I guess I would throw it back on the women in the room. I think it's up to us to really be an example for other women. I think in some ways women have an advantage, and I'm just going to say this very bluntly. There's definitely a lot of egos in the healthcare space, and I think that being a woman, there are advantages to you can kind of avoid them a little bit. So I think that it's about finding your own voice, not trying to do things in the way that a man would do, but rather embrace who you are. I think men and women are very different, and I think men and women have different advantages. So trying to do things in the way that someone else would, whether it be man, woman, or just as an individual, I think it's really important to understand what your own unique abilities are, what make you be able to do things well. I don't know.
That's great. Great. Fabien, I want to jump right in with you on this issue of making hardware less of the issue. So the concept that you mentioned was you are linking decision-making around imaging, decision-making around the results of the imaging, and letting it be available through the internet. So give us a little more detail about how you're doing that, because that's, for a community hospital, buying another big box, right, becomes really tough for us. So give me some thoughts on that.
Yeah, there's 2 points really to add. So I think the piece that we have to think about for a second is not about software, infrastructure, and IT. Is think about systemically. What do we have today? So the needs that we have is you want early and accurate diagnosis. Healthcare is its core peer-to-peer industry, fully siloed today, I would say. And you want to show sharing and all this data put to work to really help your treatment decision. Those are the needs. At the same time, you have systemically today an infrastructure that hasn't been upgraded for the last 40 years, isn't it? All those on-prem solutions you have to install. And the problem you have with those is that not only they're on-prem, secondly, you don't have the compute requirement to do all these things that I just mentioned. You don't have sharing capabilities, and I think now more and more it's across organization as well. And so the right thing to do is to do an online platform like you have Netflix or Spotify or all these tech platforms, isn't it? The reason why it hasn't been embraced in healthcare, which is, again, obviously the right thing to do, is data privacy. And because of data privacy, people don't want, and when it started 6 years ago, when we started at Stanford, we used to go to some massive technologies and say, that's wonderful, we'll never send you data to the cloud. And so we went through the journey of like 6 years of building a solution to really enable comfortably community hospital, large academic hospital, to finally go to the web, a true web, not private cloud, real web. And then today, to this day, I think not one hospital refused to go on Arterys because of our data privacy infrastructure. And so now when you have this linchpin gone, imagine the potential of that. You have sharing across like Google Doc around healthcare. You have unlimited amount of compute, so you can do AI for any kind of detection, classification, tracking. You have AI also for predictive, so put all the data to work. You now create communities around hospitals. All of that is available when you solve that, and of course the regulatory and the data rights. And so we built that. And now we're live, for example, in a very large, I think the largest health system in France, which is a really community hospitals, very heavy population, poor people, don't have the right doctors and expertise. And that's why now they first want to embrace Arterys. They say now I can get full expertise whenever I want to, have AI like increasing level playing field on my staff. I reduce the productivity. I have resources I need to on demand. I don't have to lose heavy infrastructure computational costs are not available to community hospitals. Now they're fractional costs and on demand as you need it. And so it's about changing the framework. And that's what we spent 6 years building. I think that was important for helping make a different patient lives.
Can you be more specific as to how did you navigate that privacy issue? I mean, are you de-identifying, or how are you annotating?
Yes.
I imagine it's different country to country too.
It is. So that's what the matrix is very complex. Isn't it? You have not only you have the data privacy rights. So Europe actually is 10 times harder than US. So you have GDPR, and so we build a solution around that. So we de-identify, we break down the images, they go to different kind of servers, we re-identify them in browser with SAML for the right physician. We send the data back, we attach the name. It's a whole machinery that will bore you, I think, to hell if you were to listen to it. But it works, and I think that's most importantly. And in Europe, you have also an encryption key in the middle of that. But by doing that really heavy lift and getting to the BAA, all those like questionnaire, and successfully doing that at really top academics now in US and Europe, I think we solved that problem. Now it's a solved problem. And now the question is more like, okay, what is the automation you need? What is the help community hospital needs to really give them all? And what I'm trying to achieve is trying to create a level playing field. It could be at Mass General or in the middle of Africa, and you should have the same quality of diagnosis and care. And that's what we're working towards.
So that's an interesting perspective, Lee. When I opened up making that case about how we could manage a sicker patient post-operatively with telecritical care, Fabien's addressing that same concept of expanding the scope and reach of a community hospital. And in your experience, having set up a very broad telestroke network and now what you're doing across MGH, tell me how you think about marrying those two concepts.
It's really interesting. There's a couple of points that I would make. I think the first thing is the biggest challenge is time, ultimately. To me, it all comes down to the expert time. So you can redistribute the expertise at an academic medical center so it's available in the community, but you still, there's only 24 hours in a day and maybe only 12 to 18 working hours of some one person in any given day. So that's still a barrier. If you can embed knowledge and expertise into software, AI, other agents that can do the pre-processing or much of the work, you can further leverage that time. I don't think we're ever going to get to a point where there's no human supervision.
And we don't want that.
Right? No. I don't think we want that, but we could clearly be spending our time doing more interesting things.
For sure.
Bank tellers don't deposit checks anymore, right? They do more complex transactions because we have simple ways of doing the simple things. The one comment I would make about privacy is that I think there is still a dramatic risk for re-identification of these de-identified data sets. Yeah. They're large. I mean, Medicare, you can buy Medicare data now, and it has an encrypted unique identifier, and there's no attributes that you think would allow you to re-identify. But a bunch of stuff that's come out recently shows, if I have your Fitbit, if I hack your Fitbit account and your Stop and Shop grocery account and merge those with your de-identified Medicare data set, I can re-identify like 60% of the people. So this issue of, as we make the data more available and we leverage all these tools, it will come back to this question of trust. And that's the challenge, right? Because for the individual user, they're willing to sell a certain amount of their privacy for convenience, Amazon, Google, search, whatever you want to pick, with this sense of comfort that somehow it won't come back to haunt them any more than a targeted ad. But if it suddenly starts to impact their insurance premium or their ability to get a job or et cetera, then we have a very different conversation. The last thing I was going to say is I think as we move into this world of more distributed access, there will need to be, I think, a different workforce. Right? We're going to need to think differently about who's at the bedside, and probably we need a separate layer of almost like healthcare engineers who round with doctors, who sit next to a retina specialist, who are observing this process from a very mechanistic perspective and saying, I've noticed that 50 times today you did that thing that seemed to get in the way of everything else. Maybe we could automate that, or maybe we could just take that off your plate and have someone else do it and just deliver it just in time when you need it. So I think the next probably big iteration will have to be around how do we slowly migrate this enormous workforce, which is a huge employment engine in this country, right? How do we start to migrate that workforce so we start shedding jobs that aren't going to be needed in the future, retraining or repurposing people, creating new job types that will help embed this AI machine learning approach in a way that is really serving patient needs and not just further aggregating capital in the companies that have gotten in first.
Fabien, you had a follow-up?
Yeah, just 2 points on that. I think, I totally agree with you. I think it's all about assisting and helping. I'm sure everyone in that room probably use Waze or Google Map in some form. I presume for your survey, how many of you would like to go back to paper map? Very small amount, isn't it? So it's very clear that it's the right thing to do for a radiologist. The data privacy is a very important part. We've been going through that for years now. I think it's relative data privacy. So in a sense today, I can go into any hospital you can name on with USB drive, plug in that anywhere, and I can get any data I want. And I don't think it's as easily to do that in a cloud-based environment. Yeah. So in that regard, I think we saw the fact of now, I think head of IT and CIOs, I felt comfortable with the architecture we built, that you have the same level or actually more than you currently have on site. Yeah. And then back to your third point, which is really interesting, the change on the workflow. So I feel that today they are spending, and especially radiology, far too much work that is really not interesting. And there is a burnout issue, there's a lot of cloud computation issue as well. And so I believe that the world is trying to change. You're going to do more interesting work, all the groundwork will be taken care of for you, but also now you're going to do big data analysis, and that's the exciting part. Let's bring 10,000 similar bleeds, for example, based on genomics and EMRs and population, have those evolve over time, and what should we do for that patient in a personalized setting? And that's the healthcare we're working for, and I think that's really exciting going into.
Let me just tell the audience, you folks are on fire with the app, so I've got a zillion questions, so the panelists, don't worry that we're not going to have something to talk about here.
So the person who was first in with their question was smart.
Very smart. Fabien, one question directly to you was this issue of data privacy. The question was, when you have artificial intelligence in large data sets, wouldn't it be plausible to think that AI could de-identify and then re-identify some of that data and make privacy a problem down the road?
Yeah, we definitely use AI for some of those pieces. So far, at the moment, there's 18 classifiers that represent data privacy naming. It's very well defined. So I think the point is addressing that, and I don't think we need AI for that, so we can do it without it. But I do think there's a lot of other solutions we can do. So for example, for faces, we can deface, we can cut a layer of it to make sure there's no face that can be recognized. There's a lot of ways you can do that. So yeah, there's a ton of techniques to do that, to the point that anyone can feel, okay, now I can go to cloud safely, and my data, my patient data will be safe.
Great. John, I'm going to get to the question, but to set it up, I think what you're working on hits this right on the nose. So you had mentioned to us that in your world in retinal disease and the eye kind of being this opportunity, how do you see that linking in a community and a community-based healthcare? What possible role could that have in healthcare in a community?
I think so much of what we do every day is imaging-based. There is an exam component, but we can do most of our investigation of disease state or disease presence just with an OCT and a photo, which would allow a community center or really any place to increase their throughput and make sure that only the highest acuity patients are with subspecialists. So I think specifically for community centers where they may only have one retina specialist or two retina specialists, instead of screening 80 diabetic patients that have no retinopathy, they can screen the more advanced. Or if we move to macular degeneration, which is a severe cause of vision loss in developed countries, we may be able to just do a lot of the screening at a more remote location like a pharmacy or a primary care clinic where there may be no ophthalmologist even in-house. So you could imagine a lot of the screening and sort of disease monitoring being done at multiple community sites with less dependence on a subspecialist.
So can I just make one comment on this? Because I think there's another layer here that we haven't talked about at all, which is right now these are all in prototype, and they're good, but maybe they're good enough, but they're not the standard that we would set.
Right.
But we cost a lot of money, and it seems to me like there are huge portions of the world where good or nearly good enough is so much better than what they have, that they'd be ready to buy an AI-based solution that never had a physician involved.
Correct.
But an area under the curve of 0.8, good enough.
Yep.
And so I think there's a real potential here for this market disruptively dropping out on the physician workforce very dramatically.
Yep.
So I think
would
you know,
agree.
that when you the next step from you get the image acquired at the drugstore is you get it interpreted at the drugstore.
Yep.
You never ever see the eye doctor. You're told your eyes look good.
Yep. I mean, you'll never completely get rid of the eye doctor because we still need to do intravitreal injections until we have a robot that can do that. But
I moved from that forward, but I can go back.
But I do think it would, I think, and along those lines, the healthcare engineer or a nurse, more delivery by other non-MDs is also going to be important for this area.
So, John, the question in follow-up to that for you is, what would a hospital, namely a community hospital, have to have in order to be able to adopt a program like what you're talking about? Take aside from the technology and the kind of the sexy aspects of it, what infrastructure would be necessary?
I mean, you're still going to need, at basics, you need a skilled technician just to capture the images. I think, bad images equals bad data equals bad conclusions. So that's really at the core. But that should be very easily trainable. And then I think right now these cameras are fairly expensive, but I think over the next decade we are seeing, smaller prototypes, cheaper. There could be iPhone platforms that are going to be easier for these types of things. There's company for home OCT monitoring. So I think there will be the possibility to do this on a smaller scale, but I think you have to have image capture, technician, some sort of imaging platform, and then infrastructure to interpret, hopefully AI, and then refer as needed to appropriate specialists.
Tal, as you think about getting ready for going out to the community with your technology, give me an idea of how this would actually work. Not the call the telephone number, speak into it, and have it tell you have heart failure, but how would you actually come to a community and try and get this integrated into the care delivery platform?
Yeah, I think you start answering that question from a different approach. It's kind of like, do you disrupt the workflow entirely, or do you tag into the current clinical workflow? And disrupt the workflow entirely is a good thing, but it's almost like killing your company, like on the instant. So we're going to go with the clinical workflow. So the data we have right now indicate that if you look on chronic patients and you take one call, you can look at the number of hospitalization days they'll come back to the hospital. And we did that on CHF, but that's applicable to all chronic patients. So if you take that example, you tag into the call center of the providers or the payers that do 30 days readmission, they look on chronic patients, drug adherence and all that. And the first goal is to show, can you impact the clinical workflow in a manner that will you reduce readmission? You'll change the treatment of those patients. Because the problem is, as we all know in the AI, there's so much information available. And the question is, how do you take that information and the data and make it to executable action number one, and then you measure that number two? So that will be our two goals this year. So launch that, do some pilots, see that the nurse, for example, actually impacts, you should call this patient before you call that patient, and by that you prioritize. It doesn't mean you don't call the left patient, but it means you call everyone, and provide more insight information, and then you take Lee, you take the guy on Wellesley, you go up the ladder.
Got it. Joanna, I'm really interested in your concept of your business, and it goes directly to a question here that I think hits to one of your goals. Is your concept in your business to integrate with an electronic health record in some way?
Yeah, we integrate with the electronic
You
health
do?
record. Yeah.
So I'm just going to read this so nobody thinks that this is me talking. I'm just reading it. How do we address the weakest link of a broken electronic medical record? There are many isolated AI solutions that have to sit on flawed EMRs. It's like we're excited about building the next Ferrari engine, but have a Ford Fiesta frame. Now, nothing to say against Ford or Ford Fiestas, but Joanna, clearly you must think about this because, first of all, there are lots of different platforms out there, but many people are not that happy with their platform. So how do you address this?
Well, I think one of the aspects is I think technology is only as good as the end user that knows how to use them, and I think a lot of the technology that's been built is very complicated, and people don't actually understand how to use it. So I think next steps would be if some of these big electronic health record companies wrap some data around how their EHRs or EMRs are being utilized, it would really help improve the user experience. So something that I've realized is that the user experience is really not great. I've really never heard someone say they love their EHR or EMR, and I think that's really the easiest part, at least for me and my company. The easiest part is making our user interface great, and the way that we do that is by watching what the users do. So why didn't they click on that button? Or why did they use that in that way? That's not how we intended it. And I think Lee made a good point earlier about, I think we have amazing potential if we put some maybe project managers, project developers that understand technology into the hospital setting and look at how the clinicians are currently utilizing their technology. Because it's not that the tech, and some of it is, it's not that the electronic health records are so bad, and they're not, they could be improved, but I think they've as Dr. John Halamka has said, they're really focused on making sure that they're secure. And I think that's a huge task and a huge undertaking, and I think I'm not going to sell that short, but I think that opens up opportunity for innovation and putting things on top of those electronic health records to improve them. So I think I've had some thought. I was up at a community hospital in New Hampshire on Friday of last week, and one of the statements that someone made was, well, garbage in, garbage out. So if our staff is not entering the data properly into the electronic health record, it makes it very difficult for us to work off of that data. It's a really interesting point. And I think that's where AI comes in that some staff are new, some staff do things really well, some don't. And I think having AI making their jobs easier and making it more ensured that whatever's getting put in is accurate, I think that's what AI can help with. So,
Lee.
I just wanted to reflect on that. You know, there's this, well, I think there's a very real fear, but also a phobia about, will we become slaves of the machines or will the machines work for us? As a provider who uses an EMR on a regular basis, it's very effective as a transactional machine for the revenue cycle, right? I see the patient, they get checked in, their insurance is verified, I write some things down, a bill goes out, and it all gets closed, and it's all in one system, so that's, from a revenue perspective, that's a really good thing. But clearly, like many others, I'm sure, I feel a little bit like I'm a slave to this machine because it's telling me how to, it's setting the workflow, and I have to figure out how to accommodate to it. And I think, you know, that is, from that UX perspective, we often think about it in terms of the patient's experience, but the provider experience, I think this is a huge opportunity for innovation here, which is to say, remove complexity away from the user. So give me an interface that layer on top of my EHR that knows me, knows what I like to do, helps me figure out how to do the thing I want to do, and solve the back-end complexity by being a bridge between me and a set of computational tasks that have to occur in a way that doesn't have to be the same way that John uses it. Let us all use it in our own way, as long as the output that comes off the other end of the engine is one that the machine understands.
and I think there are companies that are working on that. I've heard of them, and I think that really is the future. I mean, if you think about electronic health records, it was 2008, between 2008 and 2015 that all of our hospitals were pushed to get on electronic health records through the American Recovery and Reinvestment Act. So this is new, and I think we have to be patient with understanding that these are new, and making the user experience for the physician or the clinicians or the hospital staff might have been something that was forgotten, but I think we're going to come back around, because as I said, that really is the easiest aspect. It's getting all the data, aggregated, keeping it safe. That's the hard part, and I think we've reached that level. And now with meaningful use, allowing for interoperability, stage 3, 2018, it's really an exciting time. So I think a lot of the frustrations that everybody's experiencing are loud and clear, and I have a lot of hope for our future. I think it was getting that base that was very difficult, but I think now that we're here, I have a lot of hope.
I do think we have to be interchangeable, though, on our application to different EMRs, different devices. There's a huge capital cost to every community center and hospital system. It's, as those mandates came out, people, chose what they chose. It's going to be a huge cost to try to, if you're thinking of trying to standardize or say this is better than that. Everyone, as Lee was mentioning, we all have different preferences, and I think we want to make sure that we have interchangeability.
Although, it's interesting because I'm old enough that I remember in the days of data science, you had to meta tag anything you wanted to know about later. You had to meta tag on the way in, right? You had to classify, taxonomify, meta tag, or you'd never find it. And in the post-Google world, right, you don't do any of that. You just do your thing. Google searches it, indexes it for you, and then helps you find it when you say you want it. So it's not in any of the vendors' interest to be interoperable, right? For them, their best interest is to be siloed, but make you buy into their silo. So the innovation there will likely not come from the vendors. It'll come from third-party aggregators who will figure out how to build those universal translators and the standards we need, like FHIR and things like that. We need those standards to exist and force the vendors to make those standards compliant interfaces available. But I suspect the innovation will come from somebody else.
Well, this technology is telling me that we are skirting around an issue that this audience wants to hear about, and that is, how do we pay for all this? So, John, you started touching on it. If I were to listen to all 5 of you, and I'm thinking about Newton Wellesley, I'm thinking, gee, there's something here for me in every one of the things you're doing. Yet I've got to decide how to pay for this, and how to prioritize it, and how to scale it. So I'm going to open it up for the panel. Whichever courageous one of you wants to jump in on, how do we think about the ROI, the initial investment, the downstream upside? How do we think about that in a world that's advancing so quickly? Fabien.
I'll take a quick stab at it. So in medical imaging, at least, it's an easy way to answer that question. So today you have to realize that I think 1/3 of the world's storage will be medical imaging. So that's just to give you context. I think 10% of hospital cost is also medical imaging. They're growing by 30% every year. So you can see that on average, community hospitals will add 5 terabytes of data every year. So you can see there's a massive cost issue around maintaining those data for years on end. And so the value of a cloud-based system, of course, you have basically, you can replace that cost you have locally with a cloud-based option with all that value added on top of it, included in that package. And so today, I think on average, hospital will spend around $5 to $10 per study. And then we basically can reduce that, and part of that also add all the viewing, the AI, and the web, and the easy access, and also on. So the cloud really help on faster, better, cheaper, systemically.
Other thoughts about cost?
I can jump in. I think in the end of the day, unfortunately, if I get reimbursement, someone else will not get reimbursement, right? So we have one bucket that we have to all share. So the way to approach it, the way we are trying to, how do you reduce inefficiency in the call center initially, and by triage the patients. And our job is to demonstrate that you actually get reimbursement reduction, for example. Our job is to show that you can predict better who to follow up. And the holy grail is patient outcomes and go for a code, but that's a long cycle. So you have to show studies that not only show that the technology is applicable, but you translate that or monetize that into ROI for the community hospital, and then let you guys argue who else you're not paying.
I also saw that as a really big challenge when I was starting my company, which is why I have always kept it free for the hospital, especially in the community systems. So I know that people look at hospitals as having a ton of money, which they do, but every dollar is allocated. And so I think that when I was starting my company, I was looking at, there's this argument between the med device companies and the hospitals on who's going to pay for what, and a lot of shifting around with cost, and instead of reducing overhead. And I think that there's a lot of opportunity with a lot of different companies, as we'll continue to see with this movement of innovation, where we don't necessarily have to charge the hospital. So with my company, it's reducing the cost that it takes the med device, the implant device makers to provide their product to the hospital. So by doing that, we have another revenue stream as opposed to taking it from the hospital. So I think when you're able to solve a problem that's impacting not just the hospital, but maybe the supplier to that hospital, you don't necessarily have to charge community systems, and that's been my approach. But I think that what's been really cool about what I've found with TORq is I view it as a freemium model, and there's so much that we're doing now, for example, at the Brigham, that I never thought would be applicable at the Brigham utilizing the software that we built. But we're finding there's all these different use cases, and we can provide them. And I think that with the community systems, there might be more of an opportunity for a freemium model, and you can pick and choose what works within your budget. But then I think every company needs to have a very, very, very clear return on investment, especially given how much hospitals have spent on electronic health records, and even then, it might be out of budget for the IT department, which is understandable. And so I think looking at solutions that might have a supplier that might front that cost, because where it's costing them money, you might be able to save yourself money at the same time.
Lee, how do you make this work? I mean, you're coming from a large academic medical center with great technology, lots of great clinicians. How do you make it work for a Newton Wellesley?
Yeah, so I think your question is, it's deceptively simple, right? Because there's the question of the population health lens versus the fee-for-service lens. And in this conversation, I often talk about population health as expense per service, right? So the surgery that brings you revenue when it's from a patient who's outside your ACO is costing you money inside your ACO. The larger question, I think to some extent, is how long are you going to own that patient? Because if you invest resources up front to reduce cost of care downstream, that's only as good as the patient remaining in your portfolio. If you're in Medicare or Medicaid, you got them for life. But in a community hospital setting, they're moving in and out of commercial products, they're moving in and out of your community. So you can either look at this as an opportunity to reduce your total cost of care delivery, or as a way of increasing your revenue, right? Increasing your market share. We were just talking before the session about, if insurance companies aren't paying for a telehealth solution, like say I staff your hospital with acute stroke consultation, how in the world is that better for you? And the answer is, if it's cheaper for you in the total cost of care to access the service on demand at a capitated price than it is to hire, retain, sustain, and feed that group of 4 neurologists who would do the work of one teleneurology service. If your total cost of care is lower, that's revenue for you, because it's money you're not spending on something else. I think the problem becomes, and I'm sure you're engaged in this just like we are, when you try to think about, okay, I have to implement a 10% reduction. What would a 10% reduction look like in my department? It's people. I mean, the vast majority of what we spend our money on is people in healthcare. Now, orthopedic implants, other high-cost imaging devices, that's a section of this. Those costs are very hard to control. You either buy the thing or you don't. But in this circumstance, you have people. And so I think ultimately our industry is at a tipping point where we've been growing in labor for decades. When we try to think about improving efficiencies, that's likely to come at the expense of people who are performing manual tasks that can be automated, or who are going to increase their productivity, so that if the images are all pre-processed by the AI platform or by the OCT, and now I only have to spend 2 minutes on an image instead of 15, well then my one doc can now do the work of 3. So do I really need all 9 of my docs, or now do I only need 6 or 3? So I think that's the real boogeyman, and the question is, what do we do with all those people if in fact these promises come true?
Yeah, my angle is on the same line. Sort of for ophthalmology, you should be able to reduce personnel and also potentially be available at other times. I mean, if the OCT and the fundus photo can run up till midnight, you can get people after work. It's going to be, you may be able to expand your patient pool and bring more people into your center, even though less are coming through the door between 8 and 5. Bank teller hours, and you don't need a technician check-in. All these things, requirements are less.
So one of the questions here is, there's some really great questions that I think are going to test us all, but one that's interesting is, as you're thinking about your own endeavors, is a community hospital an early target for you as a customer, or is an AMC a better first target for you, and why?
So for us, it was always, it is community hospitals. That's where we have done the vast majority of our work, because that's where the need is. So in the community, there's a desire for access to expertise that isn't reliably present, and the AMC is a natural reservoir of that. I think the real question in my mind is, how do we move from the model of community hospital as consumer of a service, with the AMC as the provider, to actually thinking about how to promote and innovate change within the community hospital, so they start becoming the provider of this work, or they pool their assets across other community hospitals and become kind of synergistically, in many ways, an equal partner with the academic medical center. One-on-one, it's always David and Goliath. But the community is where a huge amount of the care is delivered, right? By definition, how many AMCs are there versus community hospitals? If we can't figure out how to bridge that gap so that the perception is AMC is really expensive but really high expertise, community hospital is affordable but not as good, we have to figure out how to level that so that people can feel they can go in and conveniently access really high quality product in their community at a lower cost.
Yeah, I think the community centers are where the target for a lot of these screening projects would go. I still think, academic medical centers, I'm trying to focus also on subspecialty, subclassification and phenotyping to better, identify phenotypes. And I think, as mentioned, Lee mentioned, trying to then translate that to community. But I think kind of there's two different buckets, and eventually those hopefully will merge.
Fabien, you already said you're in a large health system in France with community health.
And also in the US also. So I think a lot of the time when I go to an academic center, they say, this is great, I love your AI. I have 10 fellows doing that for me every day. So I may not need your AI.
That's natural intelligence.
Yeah, exactly, which is great. I think, but it's academics adopting for different regions, which is about baselining and so on. But for community, boy, this is where the need is, isn't it? Like, they don't have the expertise, they don't have those overload radiologists, they have those burnout issues, they have those costs really piling up. And so at Arterys, I think we have really a category to really make that happening and available. It would take on the bulk of the biggest application for them, actually. So chest, CT, X-ray, breast, neuro, and so on. And also we have a program that started really enabling other practices that don't have the same resources in the US and Europe also, to make the same AI available to the world, to help communities that don't have also the same means, because we believe in that equalization and democratization of quality of care. And so that's what the web can do very, very well.
Joanna, you're mentioning the work you're doing at the Brigham, but then you were in New Hampshire last week. So where's your target from a community setting?
It's really all of it. So I think when I was starting out, I was trying to think about how do we scale fast into, it's a big goal, but every hospital across the country, because that's how you have the biggest impact on the overall cost for these enormous orthopedic suppliers that are really struggling with their costs. And I think that the community hospitals, that's where the volume is. So being able to provide a solution that the community hospitals are able to afford, I think goes back to the question of price. I think it's a critical question. I think we have done a lot of, so we're also in the Faulkner, which is community hospital, and a bunch of other community hospitals in the New England area, but there's no, for my space, there's no set person in a lot of the community hospitals, because there's not the resources to double check, is the vendor coming for tomorrow's cases? Are the trays here? And if you don't have the trays and you don't have the vendors, or you don't have the implants, that surgery is getting canceled, which ends up costing all hospitals a lot of money. Like at the Brigham, for example, there's a couple of charge nurses that oversee, they look through the schedule. Well, this was prior to having our product. They would read the schedule multiple times a day, printing it out, double checking for changes, and then call every vendor asking them, is the product here? Are you coming in for surgery? You know the schedule got changed, and we just automated all that work. So the same applies in the community systems. We did the exact same thing, looked at what the workflow was, and then just automated that workflow. And so I think that's really critical. But the one thing that I would say for community health systems is academic, from my experience, it's been, some of the academic systems are a little bit more, I think, able to take on risk. And I think in that, I was talking with someone about this, a CIO, and they said it's because there's a larger budget. If things go wrong, they have the budget to handle it, and I understand. I think my fear is the status quo being something that's less scary than change. And for me, the status quo is much more scary than change, especially with our patient population growing. So I think one of the things that I'm hearing sitting here is less about price and fear of being able to allow things into budget, and more about, are people going to embrace change? Because we talk about cutting jobs, and right there, that's scary for everybody. So when you approach a hospital system and you say, I can do this for your system and I can cut X number of jobs, then you have to talk with those people whose jobs you're cutting. The first thing they're thinking about is, well, what about my job? And I think that we need to kind of shift that mindset, because it's hard from a leadership position. If you're the CEO of a hospital and your people are saying, I don't think this is a good idea, is that coming from a place of fear that they're going to become irrelevant? Or is it coming from a position of, this is not what's best for the hospital? So I think it's very difficult for leadership to be able to decipher between the two. And I would challenge at community systems, I see a lot of that fear. A fear of change, and I see it at academic as well, but I see it more in community systems. And I worked in all of our hospitals in New England before I left to found TORq, and I think that that's my fear is not that hospitals won't find the budget, because if you can show a clear ROI, I think they will. I think that people that the leadership listen to that say this is not a good idea, I think that sometimes that's definitely the case, but I think other times it's a fear of, am I going to become irrelevant? And we're talking about it. A lot of positions are going to become irrelevant. But I don't think of it like that. Those positions, like, again, I think Lee said this, there's more exciting positions to be had. We can make a job that used to be one thing into another. So it's not necessarily cutting staff, although it is that as well, but it's also taking the really smart staff that you have, improving their quality of life while reducing the amount of work that they have, and also allowing them to use their skill set and avoiding some of the mundane stuff. So I think I shifted it a little bit, but that's what I've been thinking a lot about as we've been talking.
And Tal, do you see a community hospital as a target early on in your work?
Yeah, it's hard to follow Joanna after that. It's like, thank you. But definitely, the challenge always when you sell AI, robotics, medical device is you have to get that big leading institution, whether it's the Partners Group, the Mayo, the Johns Hopkins, just for validation, because I agree, community hospitals are reluctant to take risk for various reasons. One. Second, they usually want validation outside of their system. I think, Mike, you're leading innovation, which is very unique to community hospital. Not all community hospital thinks like that. They think, how do I go home at 5 o'clock, relax, start the next day, and how do I don't need to innovate myself. I'll be a good follower. I'll let it come, wait 5 years, it'll come to me. That being said, for us, when you think about we're not looking at the treatment of the patient, but pre and post, that's community hospital. That's even one layer above them, which is the PCP, or even just calling friends and family. And for that, we have to go to the community hospital. So the way we think, we have Mayo Clinic working with us already. They led our first vocal biomarker study. We have to get some of those tertiary care academic center to publication and fellows to write a publication and all this research grant, because community hospitals don't have that infrastructure to validate. But the market is definitely the community hospital. The market is also the home care, but that's correlated to community hospital. Because I'll call my PCP or Newton Wellesley, which that's where I go when I need an X-ray. I will not go to the MGH of the world. So I think the balance is also very important, and how do you, as a company, bridge between that. Also, usually the big hospital wants things for free early on, whether surprisingly, whether community hospitals are looking more into ROI, and sometimes they can take more risk on the financial element if it's not a big cost, and they can do a small validation study that you can also isolate that output of that, and not just in a big study. There's so many things and fellows that maybe impact the placebo effect that you don't want to have.
Lee, there are two questions here that I think work well together. If you're going to take expertise that exists in an AMC and push it out to care in a community hospital, what does that do to the community hospital as a broader site for care? Would people then choose to go there as opposed to going to an AMC? So that's part one.
Yeah.
And if that were to happen, what's the future of the academic medical center? If you're taking technology and moving out into the community, do you need as many, or do you need as big an academic medical center?
So let me take the second question first, which is we saw that with PCI in cardiology, right? You train enough people to be able to do PCI in the community, suddenly your cath lab looks a little empty. So you need to innovate, you need to take on new service lines. And I think ultimately that's great for, again, if we flip it around from the patient perspective, that's great. You know, I remember when I was a kid and we would drive across country, you'd see 35 different brands of gas stations. And I always wondered, like, how do you know to trust? Can you trust Esso? Can you trust, you know, the green thing with the 2 letters? Like, how did you know?
You're dating yourself.
I know, exactly. Esso. Anyone here know Esso? Yeah? There's 3 people. Okay. This was before there was consolidation and having only like 3, oil and gas manufacturers in the United States. So there's a certain amount of trust that you need to have that the quality that you're getting in the community is measurable in some way as equivalent. Maybe that's reputation, it's peer, it's the brand of the AMC stuck on the door outside the clinic. I think one of the pieces, though, that one of the risks here, and it's more of like a reputational risk, I think, than a financial risk, is does it say something good about me or bad about me if I'm a community hospital and I am borrowing expertise from somewhere else? Is it like having a Ralph Lauren boutique, inside my shopping mall? Or does it somehow lower me because I can't do it myself? And I think initially we did have some resistance to the idea that, well, what does it mean if I say I can't have a neurologist on site or a psychiatrist or an endocrinologist? Does that mean I'm adding more, or does it mean I'm a lesser facility? One of the things that we have not heard a lot about, and I think this will be an important chapter in the next decade of sort of AI, is we keep talking about replacing what's missing in the community, as opposed to AI educating the providers in the community to make them as good as providers in AMC. Part of the issue is the AMC pedigree has people who trained at the top of their field, right? So they come in with a selection bias for highly motivated, highly talented individuals. But all of us who practice in an AMC know what makes us stay good is the AMC we're in. It's the community of people talking, raising questions, learning new things. I attend on service. Every year I attend on service. Whenever I'm on, I learn new things from the residents I'm supposed to be teaching. So part of the problem, I think, is that the AI right now doesn't replicate our training experience. It doesn't sit you down, show you the answer, show you why it's the right answer, not show you why 7 other cases are the wrong answer. It's just efficient, right? It just tells you, here's the answer. So I think if we want to really build capacity in community hospitals, we have to rethink the AI engine a little bit so that we're educating the community radiologists. So they are now an expert on reading, mammography. They're not just getting an answer spit out for them, which they're then handing on to the next person. Did that partly answer the question?
Yeah, so that preserves the academic medical center for more advanced therapies that clearly require a team at the AMC and all that.
I mean, I think it's no mystery that in Boston we're overbedded for AMC beds and underbedded for community hospitals, and it just shows you that sometimes supply drives demand, not demand driving supply. And so if we had 1 large or 2 large major medical centers and then a ring of community hospitals, we would do things differently. The reality is we're starting with all these AMCs, and so I think it's very challenging to figure out how you go forward here, because clearly as we drive down the cost of care and we move technology and sophistication into the community setting, more care ought to happen there. But then we have a lot of these open beds in the AMC, and we need to fill them to run the engine that drives the innovation and drives all the work and is an employment engine in the city. And so I'm not sure. I mean, there are a lot of companies that went bankrupt over this process, right? So how do we avoid waiting so long, being so risk averse that we sit in our silos until suddenly we have to make a 30% budget cut? How do we start trimming and reshaping ourselves for this expected transition? And I think I see it a little bit in some of our departments. More and more of our AMC physicians are actually now practicing in the community. Some of them became chiefs of service, some go back and forth, but more and more common is the surgeon operates 1 day a week or 3 days a week in New Hampshire, 1 day a week at Mass General. So maybe that's part of the solution, is that we start to diffuse the physical geographic location of the expertise.
Fabien,
Yeah, I think two pieces. Actually, we're doing exactly what you mentioned. So we share workspace across Arterys, and then you can see the answers before and all of that. So I think we definitely try to help bringing. But I think what is interesting, your comment, I think is very rooted in geography, isn't it? But I think the web-based fashion doesn't have that concept, isn't it? Why do you think about a community around Boston, isn't it? Like, you can take care of patients all over the world in a web-based fashion, isn't it? So change the paradigm. I think that what is exciting about healthcare is the notion of data-driven medicine. That, I think, for me, is the most exciting journey we're going to embrace, and the big data approach to medicine. And if you get those data to suddenly surfacing up, I'm sure that there'll be a lot of value in communities, a lot of other values in academics, and they all work very as an ecosystem again. And I think they won't be localized as well. They will be globalized. And I think that'll be an exciting journey of seeing how can we help crossing the chasm of not just like physicians that went from Mass General to a community hospital in Boston, but around the world, isn't it? And get those communities and that value being diffused across. And I think that's one of the pieces I think we're working on.
This is a really interesting, provocative question. I'll open this to anybody. Who owns the data in an electronic health record or a medical image? Does the hospital own it? Does the patient own it? Does the company own it? Who owns it? And if it's not the patient, shouldn't it be? So, Fabien.
Your space start.
Go ahead.
No, go ahead.
So we worked on that. So in the rule in the US are very well defined on that matter, actually. So is 50-50 roughly, is it owned by the patient or by the hospitals? Definitely never owned by us. And I agree with you that more and more it goes to the patient, I think. That's the trend, I would say.
Yeah, I will agree. I think the company wants to own that. As a company, we always want to own the data. That's what we have, but that's not the right thing. I think eventually it has to be in the patients with rights to the hospital. Meaning this is the patient information. I remember my son was sick and we got MRI and I had to go and ask specifically download the CDs. I still have a library of CDs and then load it to Google Drive just so I can track them. Because I don't have my own EHR, but I didn't want to trust that EHR. I want to own the data for my son.
I think it's a really provocative question because there are certain things about the patient's data that are intrinsically the patient's, their DNA, right? That signature, that code, we are writing it down, but it is not. We're not creating a new phenotype, right? We are just simply codifying something about the patient that exists. There are other things that we do where we actually create new knowledge, new information that is about the patient in relation to other things, their environment, other people, that I feel like is new. It's newly created value. And what we probably need to do is try to look, for decades, for hundreds of years, there was an implicit economy in this, an unspoken economy. Patients, you acquired the knowledge of their illness, their condition, their response to treatment with the understanding that that would make you a better doctor to care for the next patient, and that they had benefited from that accumulated wisdom before they came and saw you. But now that we are monetizing all these things, it seems to me that we need to start trying to understand how, just like if we have an academic industry partnership, we talk up front about the intellectual property, how we're going to divide that, how the contribution will be recognized in a monetary way. I think we're going to have to figure out how to structure that dialogue, either at the level of communities or states or individuals, because in order to drive this engine, we have to try to extract the value that comes from that, and much of that innovation is then driven by monetization of that value to allow new companies to form.
And also aggregated. I think one of the pieces that we've heard a lot is a lot of the health center we're talking to say, well, I don't want my data to be used by someone else, or my data is very important, my inputs are very important. But I believe that's a kind of short-term viewpoint, isn't it? Like, I think everyone in that room, I'm sure when we have a close relative who is sick, we would like to boil the ocean for them. So they want to mine 1 million cases around the world and find the exact similar patient with some genomics and what happened to them and all that information to really help. And that will never happen into one single location. The data cohort is too small. And so I think that's like aggregating all that data and passing that Rubicon to make that happen. I think it's a very important part of a true different healthcare for me. It's big data driven.
I think the provocative part of the question that he asked is it really the groups, do they have a right to share that patient's data onward? I think it's a good question. I don't think there's a
back
perfect
to data
answer
privacy,
there.
isn't it?
Yeah.
And it's also it's a chain of custody, right? It's one thing to say, I let you look at my data and even use it for research or teaching purposes. Yeah. but I want to be able to audit and track where my data moves.
Right.
Because I might want to revoke permission in the future to allow it to be part of a military device that would be used to blind, soldiers in combat, right? I want to restrict the use of my data. So it seems like at some level we need to think about whether it's blockchain or some other technology, but a data custody mechanism so that I can agree to, it's not black and white. It's not like I either give up all my rights or I give up none of my rights. It's that I have the ability to understand and potentially negotiate. If my data becomes extremely valuable, I want to understand how it's being used.
So you mentioned blockchain. Fabien, give us your sense. There's a lot of questions here about, is blockchain the future to manage access rights for patients?
So we looked at that heavily at Arterys. I think there's two pieces on blockchain. So blockchain doesn't give you privacy or security. It gives you traceability.
Yeah.
And so that's very important to understand. And the second piece, if you understand how freaking expensive the compute costs of running blockchain, you have the equation and the answer right there. It's so expensive. And so I think it's not solvable at the moment. I don't think it's a solution. I do think that you need to have some traceability to the system. I think you can achieve that without blockchain. And I do think we need traceability, you need privacy, you need data. But I don't think blockchain so far in the way it's been architectured is looking forward is just far too expensive, I think.
So we're, just to let the panel know, we're at about 8 minutes, so we're going to have to try and fly through the rest of these here. But Joanna, just to start off here, in your experience in your business, there's a question here about the fact that it's hard sometimes to get academic medical centers to buy into pushing technology, experience, skill to a community hospital as opposed to keeping it for themselves. So what's your perspective on that?
Sorry, do you mind repeating that?
So Lee's talking about how they take great skill and technology and push it out to community hospitals. And yet someone in the audience believes that academic medical centers don't always buy into that concept. They'd rather be territorial and hang on to it as opposed to sharing it out in the community. Do you have any sense for that?
Well, my company we don't really cross over into that area. So yeah, I would say that I haven't experienced anything like that. It's more that there's a different way of doing things in academic versus community. So I think the way in which I would tailor the conversation would be very different if I were at an academic versus community. But I'll let someone else.
How about you, Lou? What do you think about
I think
this kind of holding on?
I think it's all about risk. Actually, I think you guys over there said it really well. That the perception of risk and the attitude toward risk is really different. Community hospitals will take risk in some areas way more than academic centers and vice versa. And I think as long as the academic medical center feels that there is a line around the block to come in, and it's a line of people with the right kind of case mix, they're happy to share. When they worry that the supply is dwindling, they suddenly get competitive with the community hospitals. Even in their own networks, they get competitive with the community hospitals because I don't think we have yet figured out how to bridge that cultural divide. And I think you went from working in the heart of a very large academic medical center to leading a community hospital. The physician culture, the provider culture is very different. And there's still lots of, unresolved tension and conflict between how those two groups view each other. And so I think that it's a very live issue. Especially as we start talking about risk and cost and reducing the cost of care, AMCs need to think about evolving that culture and that concept if they're going to continue to lead. Otherwise, as success and automation and all these other things level that playing field, the cost of care is so much cheaper in the community. Then the big danger is the insurers shift. And if the insurers shift to preferentially reward community hospitals, the AMCs, are in a crisis.
But Lee, to carry on that, PCI is a great example of that, right? It started with only MGH and Brigham, and they are doing PCI. Reimbursement was very high. You have to keep the patient for 3-4 days, and now look at this. You start in the morning, you go out at 3 p.m., and the reimbursement has to force you 1-day discharge. So they actually evolve that knowledge, and then the AMC is now doing a percutaneous valve, which the community hospital is not doing. So it's all, how do you feed the funnel of innovation And to me, the same example on the company structure, or as a manager, your job is to train your successor, which is very counterintuitive.
Yes.
And I think the same apply to AMC and community hospital. How do you share the knowledge?
How do you make the community hospitals more like AMCs, and how do you evolve the AMC to be something new?
Yeah.
One other point I was going to touch on just is remember the consumer, the patient. I mean, there is a culture. Some patients are very specific. They may have the most benign, basic condition, but they insist on always going to, their perceived number one place. And then people with very complex conditions may just refuse to drive more than 10 minutes from their house. So I think you can't predict exactly how accepting the consumer will be of these types of AI implementation devices, and it's not a given that they will accept these things in the community.
Fabien?
Yeah, so far I would say that on the data point of what we've seen so far, I think there's an overall majority say they want to embrace it, and also they're willing to share data, which is something we didn't have 5-6 years ago. There was a lot of fear that we'll replace radiologists. That's out. This is over now. And now there's a willingness of seeing that value being created and channeled. So that's something that could be an interesting data point of several hundred hospitals. Yeah.
So I'll remind you when I ask you this next question to the panelists that you're likely going to get quoted either now or a year from now. But this is your prognostication question. So someone in the audience says, listen, when you come to these conferences and you hear about innovation, everybody's all excited. They leave the room, they're thinking about what is going to happen. But how do you actually get from this panel discussion to pushing these types of concepts out into the community in a reasonable time frame that will have a real impact on patients? So I'll start with Tal. We'll work back this way. But I'm just curious, how do you get from where we are today, Tal, to actually making this work in a community hospital setting?
It's fun because I share the same question all the time when I hear those vision of 2025, and it's already 2019, right? And you just start slow, right? And if you look on the life of a startup, Monday is usually a bad day, bad result. Tuesday you're depressed, and Wednesday, Thursday you're good, and then Friday the weekend arrives. So
Friday is the IPO.
Exactly. So it's a cycle, and you just have to start slow. But as a startup, we don't have the luxury of, we have 2 or 3 shots on goals. So you have to pick the right partners, and to pick that partners that commit to your goal and not just to show off like one study, one publication, New England Journal of Medicine, whatever that. You have to pick that sweet spot that you can make an impact. It sounds very high level, but that's the reality. You have to, and the most important thing from my perspective is this team. You have to surround yourself with people smarter than yourself that can just push you, and they will hire people smarter than themselves, and so it's all about the team in the end of the day. But it's easier said than done.
Joanna?
I think for me, it's been understanding the barriers to entry within the hospitals. So from my own experience, having lived in the hospitals for 6 years, what causes people to say no, and how do we avoid those bottlenecks? So workflow change, first and foremost. That is something I am always aware of. Never change workflow. It's a barrier that I just wouldn't even want to go. I wouldn't want to go through. 2, understanding you need a very, very, very clear ROI unless you're free, and even then you need an ROI because you're proposing a risk. So I think those things are the things that I focus on, and I think with those in mind, I think you can. I believe, having founded my company 3 years ago, and now we're in 13 hospitals, which I'm really proud of and hoping to scale faster, but I think it can be done if you understand what the bottlenecks are and the barriers, and don't think you can work around them, but you can work around them, but understand them when you're coming up with solutions.
So Fabien, quick answer, how do you get out into the community?
So I think for me, it's also about the innovative aspect of the community. Some are more innovative than others, and picking those and finding those. And I say on top of it, the full solution that addresses the community needs will be done by, I think, end of this year or RSNA, I believe. So at that point, I think they can come and have a full kind of offering that give them AI across the core modality this year, I would say, or beginning of next year.
John?
I'll be really quick to make sure Lee has enough time, but just I think making sure you have enough IT infrastructure on the back end. I feel like that's been the biggest roadblock I've seen with trying to implement any system or algorithm.
Lee?
I think you have to be relentless. You have to be committed, relentless. It has to be your number one priority if that's the thing you want to see changed. And you need to be able to explain to people why it's so important. If the only reason you can come up with this is going to save us a couple of dollars, I think that's a really tough sell. If this is going to make a huge difference in the lives of our patients, that seems to be that's a pitch that works extremely well to align providers. But I agree, you have to make sure you try to follow the workflows, but inevitably you're changing something. And so you have to help people see beyond the hill of the change to the sort of valley of opportunity.
Well, let me thank all of you for coming, but really the panel, just phenomenal job. Thank you very much. Thank you. Enjoy the rest of the meeting.